Hello everybody, in this video lecture we will cover physiology of circulation. Let's go ahead and begin. So blood flow. So first we're gonna look at some terminology over here. So what is blood flow? It's a volume of blood flowing through a vessel, organ, or entire circulation in a given period. So it's a volume over time, right? And it's measured milliliters per minute, right? So milliliters per minute, so as you see, it's volume over time. Now, it's equivalent to cardiac output. So pretty much the flow equals cardiac output, right? So let me see if I can, flow equals cardiac output, because flow is milliliter per minute. If you remember what cardiac output is, it's amount of blood, right? Again, amount of blood pumped by your heart per minute, right? So that's the same stuff, right? Flow and cardiac output. Keep it in mind because that will be important. Blood flow is relatively constant when at rest and varies widely through individual organ based on needs, right? So let's say how much blood flow your skin need, how much blood flow your heart needs, or your brain, right? Also depends on if you're resting, for example, and digesting, we need more blood flow to your digestive system. When you're exercising, we need more blood flow to your skeletal muscles, right? Now, blood pressure, that's another terminology. It's a force per unit area exerted on the wall of the blood vessels by the blood. So when your blood flowing through your blood vessels, of course, it exerts some pressure, and this pressure is called blood pressure. It's measured in millimeters of mercury. And we measure it when you hear a patient has 120/70 or 120/80 or 110/70, right? This is the pressure in the large arteries near the heart. And you're probably familiar that the most common place to measure arterial blood pressure is the brachial artery, right? So, and we can imagine that blood pressure is not the same in your arteries and in your veins or in a small arterioles or in capillaries, right? So, so what we referred to blood pressure when we're talking about a patient, we're referring to arterial pressure in these large arteries. Pressure gradient provides driving force that keeps blood moving from higher to low pressure area. That's obviously, so let's say if you have a blood vessel, right? And for example, you do have some pressure. Maybe you have like 110 here, milliliters, milliliters mercury, right? So that's the measurement. And you have 110 over here, then you don't have pressure gradient because at both sides of this blood vessel, you have the same pressure. So you don't have this force that would allow your blood to flow. So, but when you change this blood pressure over here, for example, you have 100 over here and 70 over here, that's your pressure gradient, and it will be the driving force to keep your blood flow. Now, what is resistance? Resistance is opposition to flow, and it's measure of the amount of friction that blood encounters while moving through blood vessels, and generally encountered in the peripheral systemic circulation. The three main sources for resistance is blood viscosity, total blood vessels length, and blood vessels diameter. So you can see that, so again, if you have blood vessel over here, And inside we have blood, right? Plasma and formed elements mostly. So the higher viscosity of the blood, what do you think? It's gonna be higher resistance, right? Higher resistance. When we have longer vessels, also higher resistance. Now, blood vessels diameter. So if you have blood vessel like this and blood vessel with a smaller diameter, right? So obviously resistance. So when we increase blood vessels diameter, right? So like over here, when we increase it, then resistance decreases, right? So it's inversely proportional. So factors that remain relatively constant for resistance. So what affects the resistance? Blood viscosity and total blood vessel length and blood vessels diameter, right? So what do you think here stays, pretty much constant? Blood viscosity that should be in a normal range, right? If you have a healthy patient, if the liver works properly, if kidneys work properly, the blood viscosity is supposed to be constant. So the thickness of blood due to form element and plasma proteins, right? Blood vessel length also pretty much, in your body should stay constant. But we know the longer the vessels, the greater the resistance. So why would we have, longer blood vessels? For example, people with obesity, like so the bigger the, your body gets, the longer your blood vessels are, right? So that's also, we can keep in mind that when people gain extra weight, that increase their, the overall length of their blood vessels, and this increase the resistance for blood flow. Now, so those were the factors that remain relatively constant. Now, we do have factors that affect resistance, but that they can be regulated. And this would be vessel diameter and cardiac output, right? Because vessel diameter, that we have vasodilation, vasoconstriction. So vessels, your blood vessels, they have smooth muscles in their walls, and that allow muscles to contract and constrict those vessels, or muscles relax and dilate the vessels, and it can be regulated. It can be regulated by endocrine system, by nervous system, by some local chemicals that we will talk in a minute. But cardiac output, from the previous lecture, we know that cardiac output equals stroke volume, right? Just reminding you, cardiac output equals stroke volume multiplied by heart rate, right? So heart rate can be regulated, right? Let's say by your sympathetic nervous system can increase heart rate. So that would, this would increase the cardiac output. Stroke volume can be also regulated by increase the contractility of heart muscle of those of this myocardium, right? So also can be regulated, let's say, for your by your nervous systems that also increase cardiac output, right? So we can, your body can regulate this resistance, right, by regulating vessels diameter and cardiac output. And some factors should stay pretty much constant, such as blood viscosity and blood vessel length. So that makes sense, right? So just want to remind you what we're talking about over here. So we pretty much kind of like decided like, okay, let's get straight with all this terminology. What is blood flow, right? What is blood pressure? And what is the resistance, right? And even cover what factors can regulate this resistance. Now relationship between all these factors, between blood flow, blood pressure, and resistance. So we covered what blood flow is, what is blood pressure, what is resistance, how are they related? Well, to see how they're related, here's a good formula over here, right? Because the flow is directly proportional to pressure gradient, right? What does it mean? So again, if I have a blood vessel over here, have blood vessel, and I have pressure here 120, and I have pressure over here that, let's say 110 millimeters mercury, right? What is my pressure gradient? Only 10 millimeters mercury, right? So what do you think? My, flow of the blood here is gonna be, high velocity or low velocity? Is it gonna flow fast or slow? Well, this is not very big pressure gradient, so I expect the velocity of blood flow to be, low, right? But if I increasing this gradient, right? So over here now I have, for example, I don't know, like 70 or 80, right? Let's say I have 80 over here instead of 110. So now my difference is 40, right? 40 millimeters mercury. That's my pressure gradient. So I'm increasing velocity. So that means when pressure goes up, right? You can rewrite it like flow equals pressure gradient and divide by resistance. So when pressure gradient goes up, it increases the velocity of blood flow, right? So that's directly proportional. And it's inversely proportional to the resistance. Because when resistance over here, right? When resistance go up, right? So this number became bigger and bigger and bigger. So you divide by 1, or you divide by 2, or you divide by 10, right? This became smaller, right? So that's the relationship. So blood flow is directly proportional to the blood pressure gradient. When blood pressure gradient increases, blood flow speeds up, and blood flow is inversely proportional to peripheral resistance. If resistance increases, blood flow decreases, right? Okay, so that's the relationship between these three characteristics of physiology of blood flow, I would say this way, right? So resistance is more important in influence of local blood flow because it is easily changed by altering blood vessel diameter, right? So, so instead of dealing with this pressure gradient, your body can regulate resistance, right? And this will affect blood flow. And remember why we even care about blood flow so much, because blood flow equals cardiac output, right? So you can regulate this cardiac output, and you can regulate the amount of blood that's reaching your different organs and tissues. Okay. Systemic blood pressure. Why we call it systemic blood pressure? Because if you remember, we have systemic circulation and pulmonary circulation. So systemic circulation is blood reaching oxygen pumped by your blood to your organs and organ systems and returns back from your tissues, organs, right, back to the blood. That's our systemic circulation. Pulmonary circulation, when your heart pumps blood low in oxygen and rich in carbon dioxide to your lungs, and then blood returns from your lungs back to the heart, now rich in oxygen. So that's pulmonary, right? We're talking about systemic blood pressure over here. So systemic blood pressure is highest in the aorta. It declines through the pathway. So you can see over here how it declines, and it's almost zero in the right atrium. And steepest drop occurs in arterioles, right? So you can see over here, we have aorta, then we have arteries, and we have arterioles, capillaries, venules, veins, vena cava that return blood back to the right atrium. Okay. Now, systolic pressure, you heard about, pressure 120/80, right? Or so when we're talking about systemic pressure, we always have like two numbers, right? The first number is systolic pressure, and this is pressure exerted during ventricular contraction. And diastolic pressure is the lowest level of arterial pressure when ventricles are relaxed, right? So we only have these double numbers, systolic and diastolic pressure in large arteries. When we get to arterioles, when we get to the capillaries, then we don't have systolic and diastolic pressure. We just have one number. And we even call it differently. So again, we will cover it in this chapter. But right now, arterial blood pressure in large arteries are represented by systolic and diastolic pressure. Now, what is pulse pressure? Do not confuse it with your pulse. Pulse is completely different stuff, right? This is called pulse pressure, and this is the difference between systolic and diastolic pressure. So if I have this patient, right, what would be my pulse pressure? My pulse pressure would be 120 minus 80, right? And it would be 40, right? If I subtract it correctly. So that would be pulse pressure. Another measurement that we can use in relationship to arterial blood pressure is MAP. MAP is mean arterial pressure. So we just use this pulse pressure, right? And we can use mean arterial pressure. And this is the pressure that propels the blood to the tissues. Now, mean means average, right? So, but it's a little bit different over here. So if, let's say you have patient 120/80, and in math, if you have two numbers, right, 120 and 80, how would you find mean? You would add, divide by 2, right? That's not how it happened. This is not how it's done to calculate MAP. MAP actually gonna be, because pressure goes up quickly and then it goes down slowly. So it's not the same amount of time when you have 120, like let's say in my brachial artery, I have some, period of time that my blood pressure is 120, and then, some times that I have my blood pressure 80, right? And, all the stuff in between, but it's not the same amount of time. My blood pressure goes up quickly and down slowly. So that's why to calculate MAP, you need to take 120 one time, right? And plus 80 and divide by 3. So now it's average, right? But it's average of 3 numbers instead of 2 numbers, right? So that's your MAP. It's a systolic blood pressure plus diastolic and diastolic again, and divide by 3. That's my favorite formula, right? This one, you can also use one over here. That is diastolic plus 1/3 of pulse pressure. That is actually pretty much the same, right? This is just easy to understand. Why all of a sudden we take systolic one time and diastolic twice and divide by 3. It does make sense, right? So that's MAP. Now capillary blood pressure. So that was arterial blood pressure in the larger arteries, right? Close to your heart. Now we're moving further away, and we get to capillaries. Now you see, now we use one number. Capillary blood pressure ranges from 15 to 35 millimeters mercury. Low capillary pressure is desirable because your capillaries are very small, fragile blood vessels, and high blood pressure can rupture them. Most of the capillary are very permeable, and that's allow you to do this exchange between your blood and between tissue cells, right? So that's That's also, if you have high blood pressure, we pretty much squeeze out all the plasma and possibly even, who knows, proteins, right, that we don't want in any case. So again, capillary blood pressure 15 to 35 and low pressure is desirable. Now, venous blood pressure. Venous blood pressure changes little during the cardiac cycle. It has small pressure gradient, about 15 millimeters mercury, and low pressure due to cumulative effects of peripheral resistance. So small blood pressure in veins, right, and venules. Now, if we have, now think about it, if we have very low pressure gradient in the veins, but we still need to return blood back to your heart, right? And very often we need to go even against the gravity, right? Let's say I'm walking, I have blood in my legs, right? And I need to bring this blood back up against the gravity, back to my heart, right? And I have so small pressure gradient. So how would I help my vein to do their job? So here's the factors that help you to return blood from the veins back to your heart. Respiratory pump. This is pressure changes created during breathing. And this move blood towards the heart by squeezing abdominal veins as thoracic veins expand, right? Thoracic veins expand, oops, right? Abdominal squeeze. So you pretty much squeeze blood up. That's respiratory pump. Muscular pump. Contraction of skeletal muscles milk blood towards the heart, and valves prevent backflow. That will be pictured on the next slide. And vasoconstriction of vein under sympathetic control. So here's the muscular pump, just to see, they give you this visual idea how it happens. So here's direction of blood. Here be flowing superiorly, right? And here's your skeletal muscles. When they contract, they pump blood up to the heart, and there are valves in your veins that are not present in arteries and that prevent backflow of the blood. And that's why it's really good to walk, right? And, keep your moving, use your skeletal muscle. Not only it, help your muscles to stay healthy, it's also help your body to return blood back to the heart. Now, blood pressure, the same as any other parameters in your body, need to be constant, need to be regulated. So we want to maintain the blood pressure. We don't want our blood pressure goes up and down, all right? We want it to be in a narrow limits. And this requires cooperation of the heart, blood vessels, and kidneys, and supervision from the brain. So what influence blood pressure? Cardiac output, peripheral resistance, and blood volume. Right, so remember we talk about blood flow. Flow of any fluid is directly proportional of the pressure gradient and inversely proportional to peripheral resistance, right? To resistance, if we're talking about any flow of the fluid. So we can kind of like rewrite this formula, because blood flow is a cardiac output, right? So it's equals, instead of pressure, we can do mean arterial pressure, because that's our pressure gradient, MAP. And well, keep in mind like blood pressure, but not like blood pressure, but specifically the gradient, right? And resistance is a peripheral resistance. Right, so now we're talking about blood pressure. So from this formula, what is our blood pressure? So our blood pressure equals cardiac output multiplied by peripheral resistance, right? So that's why it says the blood pressure, the factors that influence blood pressure is cardiac output, peripheral resistance. Now also, Okay, I'll move up over here. So blood pressure equals, remember what cardiac output is, stroke volume, right? Multiplied by heart rate, right? That's our cardiac output, right? So that's all stuff is cardiac output multiplied by peripheral resistance. And of course, you can see that, cardiac output, blood volume effects and stroke volume and cardiac output. So actually, if you look at this formula, you can see that all these factors, stroke volume, heart rate, peripheral resistance, and as a, because these two factors are cardiac output and blood volume affects cardiac output, that's all affects your blood pressure. So everything needs to be constant to maintain blood pressure in our desirable limits. Now, that's why we need to control it. So how we control blood pressure? We have short-term control and long-term control or regulation. So let's call it regulation. Short-term regulation and long-term regulation. This is how we control blood pressure. Now, short-term regulation can be neural and hormonal. Either your nervous system or your endocrine system gonna regulate it. And long-term regulation is a renal regulation. So your kidneys will regulate it. Now, short-term regulation tells you we need to do it really quickly, right? And it's not gonna last long, right? So what can we alter to regulate blood pressure? Well, we can alter peripheral resistance. So all short-term regulation when we will alter peripheral resistance. Because again, remember, blood pressure equals cardiac output multiplied by peripheral resistance. So can we regulate blood pressure? If blood pressure, for example, goes up, what should we do? Well, how if we decrease peripheral resistance, right? This smaller, then blood pressure will go down. Make sense? And this would be short-term, easy neural or hormonal control because it's easy to regulate peripheral resistance. All we need to do, dilate or constrict blood vessels. Long-term regulation will take time and it's gonna last longer, and this will alter blood volume. So, and if we alter blood volume, what are we regulating over here? Cardiac output, right? So again, if let's say if blood pressure goes down, right? How about we increase cardiac output and then we can decrease, and then we can increase blood pressure, right? So blood pressure goes down, increase cardiac output, right? The amount of blood in your body pretty much, if to put it easy, and then we will increase blood pressure. And this will be long-term regulation and renal regulation because your kidney is gonna regulate how much fluid you keep in your body. You keep more fluid, that means you have more blood volume, right? So cardiac blood volume goes up, cardiac output will goes up, right? Okay, so that's our long-term renal regulation. And what are we regulating? Blood pressure. Okay, so now let's look at this short-term mechanism, neural control. Neural controls of peripheral resistance maintains MAP by altering blood vessel diameter, right? And alter blood distribution in a response to specific demand. Neural control operates via reflexes arcs that involve a baroreceptor, vasomotor center, vasomotor fibers, and vascular smooth muscles. Remember when we talk about neural control? Okay, yeah, okay, it's coming up. Now, so we in neural control. So what do we need? We need receptors, right? To tell our nervous system that blood pressure is high or low, like, so there is some change. So we need some receptors. Receptors that determine blood pressure called baroreceptors. Now we need vasomotor center. That's gonna be in your brain, right? That we're gonna in the medulla. And then we need vascular smooth muscles. Where are those muscular smooth muscles? Inside of your blood vessels. Because what we're gonna do, we're gonna constrict or dilate blood vessels. So we need the smooth muscles, right? So they are effector organs. We need control center, right, in the medulla, and we need receptors. So here's Vasomotor Center, located in medulla oblongata. It's a cluster of sympathetic neurons in the medulla, and they receive input from baroreceptors, chemoreceptors, and hyoid center. So they receive signals not from baroreceptors only, but from other parts of your body, like from your brain and chemoreceptors. Now, this is our neural control, but it's baroreceptor-initiated, right? So, where are those baroreceptors are located? They located in the carotid sinuses. So this is aortic arch, right? So aortic arch that comes from your heart, from your left ventricle. So aortic arch. So we do have baroreceptors in the aortic arch. Now those branches are called carotid arteries, right? Common carotid, right and left. And then common carotid gonna split into internal and external carotid. And in internal carotid, that gonna bring blood into your brain, right? We also have these baroreceptors. So carotid, we call it carotid sinuses. So in the carotid sinuses, in aortic arch, and also in walls of large arteries of the neck and thorax, right? Close to the heart. So, and now let me just go to the picture, right? So here's the picture, and this is the, what is that? So here's our homeostasis, blood pressure in normal range. So we're gonna control this blood pressure. We're gonna do neural control, right? Neural control through the neurons. And so it's gonna be short-term regulation, and it's gonna be done by baroreceptors. So it's gonna be this one, Baroreceptor-Initiated reflex, right? Baroreceptor-Initiated reflex, that is neural control and short-term control of your blood pressure. Now let's see what happened over here. Let's say blood pressure goes up, right? Now, when blood pressure goes up, those baroreceptors in aortic arch, in the coronary sinuses, in the large blood vessels of the neck and thorax, but here only carotid sinuses are shown. Now, these baroreceptors are stimulated. Blood pressure goes up, they are stimulated. Now, they're gonna send signal to the medulla oblongata. Now, if blood pressure goes up, what do you want? What do you want with your heart? Do you want to increase or decrease heart rate? Blood pressure already high. You want to decrease heart rate. You want to increase or decrease contractility. You want to decrease contractility. You want to decrease cardiac output. So blood pressure high, you want to decrease everything, right? You want to decrease your heart rate, decrease contractility, decrease cardiac output. Now, what do you want with your blood vessels? Do you want your constrict or dilate your blood vessels? Of course, you want to dilate your blood vessels, right? So you decrease this peripheral resistance. Resistance are smaller, right? The blood pressure, okay, rate of vasodilation. Okay, so you decrease the resistance because blood pressure, again, I'm gonna remind you, blood pressure equals cardiac output multiplied by peripheral resistance, right? So if you want to decrease blood pressure, you want all of these be smaller. You want a cardiac output be smaller, you want a peripheral resistance be smaller, right? So you want to decrease all this stuff, right? So to decrease your cardiac output, you decrease heart rate, you decrease contractility, right? And as a result, less blood pumped by your heart. If you want to decrease peripheral resistance, you want to dilate your blood vessels, right? That makes sense so far? Now, okay, so blood pressure goes up, baroreceptors are activated, they're gonna send signal to medulla oblongata. Now, what they gonna do? You have three major centers in the medulla: cardio-inhibitory, cardio-acceleratory, and vasomotor. So vasomotor center is this one. That's gonna affect blood vessels. Now, cardio-inhibitory gonna inhibit your heart, cardio-excitatory gonna excite your heart. Now, because your blood pressure already high, you wanna stimulate cardio-inhibitory center, right? So we will inhibit, we will decrease this heart rate contractility and so on. So you stimulate cardio-inhibitory and you inhibit cardio-acceleratory, right? Make sure you guys get this. And what are you gonna do with vasomotor? You don't want those smooth muscles to contract, right? So you want inhibit vasomotor center. That's, and when we decrease cardiac output and peripheral resistance, we decrease blood pressure. So here we back to normal range. Now, if blood pressure goes down, right, it's also, okay, so it also will be kind of, will be, you know, baroreceptors now are not stimulated, they are inhibited, right? And they still send impulses to the medulla. But in this situation, if blood pressure goes down, right, we want to increase cardiac output and we want to increase peripheral resistance. Because we want to increase cardiac output, we're going to stimulate cardio-acceleratory center. We want to inhibit cardio-inhibitory, and we want to stimulate vasomotor center to for the smooth muscles to contract, to constrict those vessels and increase the resistance, right? And then we go back to normal, right? So it might be a little bit confusing at the beginning, but when you look at these diagrams again, they all make sense, right? Now this was, what was it? Short-term neural control, baroreceptor-initiated, because that's our baroreceptors. Now we also have short-term neural mechanism, but chemoreceptors-initiated reflexes. And it's really similar. Chemoreceptors, well, there are some similarities, but there are some differences, right? Otherwise it would be the same stuff. This mechanism is not used that much to regulate your heart rate, is mostly, and blood pressure, it's mostly used to regulate your breathing, right? Your breathing rate. So it's not that important. It says over here, a more important in regulation of respiratory rate than blood pressure. But chemoreceptors located in a similar area, carotid sinus, aortic arch, large arterials of the neck, right? Chemoreceptors respond to rise in carbon dioxide, drop in pH and oxygen. So pH go down means your blood became more acidic, low oxygen or too much carbon dioxide. Then these receptors pretty much act through the same vasomotor center and cardio-acceleratory center. But as I said, this mechanism is more important in regulation of respiratory rate. Now, high brain center, reflexes that regulate blood pressure integrated in the medulla. We already said we have cardio-inhibitory, cardio-excitatory, vasomotor center, that's all in the medulla, but cortex and hypothalamus also can modify blood pressure via relays to medullary center. Okay, that's not it about short control mechanism. We also have hormonal control, because before was neural, right? You didn't see any hormones. We didn't describe any hormones that was released, but we can regulate it by endocrine system. And you know, medulla, adrenal medulla release norepinephrine, epinephrine, And what they do, they usually vasoconstrict blood vessels, right? So they cause vasoconstriction. They also can increase cardiac output. And another hormones, angiotensin, and angiotensin means you give tension to blood vessels because angio means blood vessels. So this this one generated by kidney release of renin. So kidney release renin, and then renin activates this angiotensin. Angiotensin actually produced, I think, by your angiotensin 1 is circulating in your blood, and it's produced by liver, and then it's converted into angiotensin 2 by renin, and it's causes vasoconstriction. Atrial natriuretic peptide produced by the heart and cause vasodilation, and ADH or antidiuretic hormone, vasopressin, that produced by posterior pituitary gland causes your blood pressure to go up, right? So it's released when your blood pressure is extremely low, right? So those are different hormones. Again, norepinephrine, epinephrine, constrict your blood vessel, increase cardiac output, angiotensin, constrict blood vessels, atrial natriuretic peptide, dilate blood vessels, ADH released when your blood pressure is extremely low, and that's acts on the kidneys, right? So kidney retains more water, right? So that's hormonal control. Long-term mechanism, renal regulation. Now, long-term mechanism, by your, regulating your cardiac output, not resistance, because everything else we looked was really a regulation of peripheral resistance. This one regulates cardiac output. So baroreceptors quickly adapt to chronic high or low blood pressure. Then long-term mechanism steps into control of blood pressure by altering blood volume. Kidneys act directly or indirectly to regulate arterial blood pressure. So we have direct renal mechanism and indirect, that called renin, angiotensin, aldosterone. Sometimes they add aldosterone over here, and you will see why. So I just go back, right? And I want to just remind you that we are talking about blood pressure regulating, right? So over here. So we're talking about how your body regulates blood pressure. Is it short-term regulation or long-term regulation? If it's short-term regulation, it can be neural or hormonal control. If it's neural control, it can be baroreceptor-initiated or chemoreceptor-initiated. Hormonal control, your endocrine system releases different hormones that either help you to raise or low blood pressure. Now we are in a long-term renal regulation, and it can be direct regulation or indirect regulation. Yeah, right, I know, right? So many ways to regulate blood pressure, and it still fails, right? Okay, so direct. Direct renal mechanism alters blood volume independently of hormones. Increased blood pressure or blood volume causes kidney to eliminate more urine, and this reduces blood pressure. Decreased blood pressure causes your kidney to conserve more water, and it rises blood pressure, right? So how it is done, when we cover renal system, actually we will talk about it, right? Because we will talk about glomerular filtration rate, right? How much, plasma we filter, how much water, how we produce concentrated or diluted urine. But right now, just remember, high blood pressure, right? You're gonna pee to kind of, decrease the volume of blood, right? Low blood pressure, you keep this volume so so you don't eliminate so much fluids from your body, so you don't pee, right? That's what it says. So either when blood pressure goes up, right, you eliminate more urine. Blood pressure goes down, you retain water, and then you increase your volume of the blood, right? You increase cardiac output. Okay, so that's a direct renal mechanism. Indirect mechanism. So let's look over here. Here or here? Yeah, I think this way. Now, just remember that this renin-angiotensin mechanism, it works when your blood pressure drops. And actually, we have way more control systems to regulate low blood pressure than we have to regulate high blood pressure. Should be opposite, right? But our body, think about our evolution. Think about this, long time ago when we didn't have junk food, when we didn't have couches, when we were not these couch potatoes people that are just sitting here and eating all this junk and getting overweight and less exercises. That's not where we came from. We came from nature, from the, back to the days when we, when we acquired all those mechanisms. We lived in the wilderness, right? And the major threat to our body was, injury. Some animal get us, bites us, we bleeding, right? So that's what our problem. And because your blood pressure drops when you lose blood. So if you're bleeding, you have huge external bleeding, right? Your blood pressure drops. So that was the main concern for survival, is low blood pressure. Now, main concern for survival is high blood pressure, but we have way more mechanism really to raise our blood pressure. And this very famous renin-angiotensin aldosterone, his aldosterone mechanism is to raise our blood pressure, not to lower it. That means the stimulus was low arterial blood pressure. So your blood pressure drops and your kidney release renin. Renin stimulates the production of angiotensin 2. As I told you, we do have angiotensin 1 circulating in our blood, and we need renin, right, to convert it into angiotensin 2. Now, angiotensin 2 is vasoconstrictor. So it's gonna constrict blood vessels, right? Increase the resistance, increase blood pressure. Also, angiotensin gonna affect your adrenal gland, and adrenal gland secrete aldosterone. And aldosterone is mineralocorticoid. And what it's gonna do is gonna cause your kidneys to reabsorb more sodium. So you keep sodium in, and because you keep sodium in, you keep water in, right? So you decrease urine formation. When you decrease urine formation, you increase your blood volume and you increase your cardiac output. And angiotensin also stimulates the release of ADH, and this is also antidiuretic. So again, you retain more water. That's all increase blood pressure. Right, so over here you can see that when arterial blood pressure drops, right, we have direct mechanism. We just decrease the filtration, right? We just decrease the amount of urine produced, increase blood volume, right? Or this our indirect mechanism when we have like a renin release, and renin catalyze cascades that form angiotensin 2, and angiotensin 2 either constrict the blood vessels, right, or cause aldosterone, ADH release, and this all increase your arterial blood pressure. So, and here we have all the mechanisms that help your body to increase your mean systemic arterial blood pressure, right? And the only thing pretty much out of all the stuff that help you to decrease blood pressure would be this. where is this? This one, ANP, right? And this is atrial natriuretic peptide. Only heart, right over here, trying pretty much to decrease your blood pressure. Everything else help you to increase blood pressure. Okay. Next, vital signs. Vital signs show how well, your body is functioning, and specifically, how well your body keeps homeostasis, right? It will be pulse, blood pressure, respiratory rate, and body temperature. So pulse is a pressure wave caused by the expansion and recoil of the arteries. And usually we take radial pulse, taking at the wrist, and this is what routinely used, but you have other arteries that can be palpated, right? So you can actually palpate pulse in the different parts of the body as well, right? Now, systemic arterial blood pressure measured indirectly by the auscultatory method using sphygmomanometer. And when you use this cuff, pressure cuff, and so here you have your artery, right? Brachial artery, that's a common place where we measure blood pressure. Now what you do, you inflate the cuff, and you inflate the cuff until you pretty much you squeeze the artery, so you stop blood flow, right? So you pressure in a cuff so strong that it's actually constrict your brachial artery, so blood is not flowing anywhere. And then you start releasing the pressure, so you decrease pressure. So, and then, finally, when the first portion of blood are moving through the blood vessel, right, that means that blood pressure and pressure inside this cuff is equal. So that you will hear the first sound. It's called Korotkov sound. And so that would be systolic pressure, right? So, and then when you stop hearing any sound, that will be, the moment you stop hearing the sound will be diastolic pressure, right? So here, pressure is released, so you inflame the cuff, then pressure is released slowly, and examiner listens for sounds, Korotkov sounds, with stethoscope. And the sound first occurs as blood starts to spurt through the artery, right? So again, back over here, you see how your artery is closed over here, so you do not hear any sound. But then you release this cuff, right? You release this pressure slowly, and then the first portion of blood pretty much spurts through the artery. That's a systolic pressure. Normally 110, 140, and sounds disappear when the artery is no longer constricted and blood is flowing freely. So it's a diastolic pressure. Right, so over here, so when blood's flowing freely, you don't hear any sounds. It just slowly, it's not slowly, but it's just moving through the blood vessel. You don't hear sound, and the moment you stop hearing them, that's the diastolic pressure. Okay, and about 70 to 80 millimeters mercury. So blood pressure varies, it cycles over 24-hour period. It peaks in the morning due to level of hormones. It's also affected by age, sex, weight, race, mood, posture, right? For example, if you stand up, your blood pressure drops. That's what posture means. Hypertension is a low blood pressure when systolic pressure below 100, often associated with long life and lack of cardiovascular illness. Hypertension, we have orthostatic hypertension. It's a temporary low blood pressure that causes dizziness. For example, if you're suddenly rising from sitting to, or from sitting or reclining position. So and sometimes when you just get up very quickly from your bed, right, it might lower your pressure and you like feel dizzy. It can be chronic hypertension, hint to poor nutrition, warning signs of Addison disease, hypothyroidism. So not enough of thyroid hormone or glucocorticoids and mineralocorticoids. That's Addison disease when you have low release of these hormones by adrenal gland. Acute hypertension, important sign of circulatory shock. Hypertension is a high blood pressure, elevated pressure over 140/90 or higher. It can be just because patient has a fever or physical exertion or emotional upset, very often persistent in obese people. Prolonged hypertension is a major cause of heart failure, vascular disease, renal failure, stroke. And we have primary and we have secondary hypertension. So primary hypertension or essential is about 90% of the condition. And this is where a patient comes and you address this problem. So you have a patient and you start address hypertension. But secondary hypertension, when you have a person with high blood pressure, but you start taking care of the disorders that associated with this condition, right? Let's say hyperthyroidism, Cushing syndrome, right? So something that endocrine glands produce, too much hormones, right? Or there is atherosclerosis, and so on, right? Or kidney diseases. That would be secondary hypertension, less common, about 10%. Okay, so next part of this chapter, we will talk about blood flow through body tissue. So what we talk over here, we talk about blood flow, right? About blood pressure, right, cardiac output, over here resistance, and how your body regulate blood pressure. So all this, good stuff. But now we're getting, so we pretty much talk about blood flow through the arteries of your body, right? Now blood flow through body tissues. That's called tissue perfusion. And it's involved in delivery of oxygen and nutrients to your cells and removal of waste product from tissue cells, gas exchange in the lungs, between your lungs and your blood, right? Oxygen in, carbon dioxide out, absorption of nutrients in digestive tract, and urine formation in your kidneys. So that's all it depends on tissue perfusion. Rate of flow is precisely the right amount to provide for proper function, right? So we don't want too much blood, we don't want too little blood flowing to these organs, to your tissues, to your lungs, to digestive tract, to your kidneys, right? We want to just the right amount. Okay, and we want to regulate, as always, as everything else, we want to regulate the amount of, because we wanted to regulate blood pressure, right? We have so many mechanisms to regulate blood pressure. Now, do we want to regulate tissue perfusion? Yes, because let's say when you're resting, this is the total blood volume that goes to your heart, to your skeletal muscle, to skin. When you start exercising, you cannot live it the same way, right? You need to increase blood flow to your skeletal muscle. You need to increase blood flow to your heart, and you need to decrease blood flow to your abdomen, right? So you can see the only thing that is not changing here is brain. Brain is actually almost at rest, or when you're exercising, or even when you study for your test. I always feel like when I study something new, I like, oh my goodness, my head is so hard. I probably have like a lot of blood flowing, but your brain is one of those organs that receives pretty constant amount of blood and does not depend much on what you're doing. Are you sleeping or you're exercising? Right, so the brain stays the same. Okay, so velocity. Well, velocity is the speed, right? So velocity of blood changes as it travels through the systemic circulation, is inversely related to total cross-sectional area, fastest in the aorta, slowest in capillaries, increases again in veins, and slow flow through the capillary allow time for exchange between blood and tissues. So what is important over here, and it's kind of like intuitive, that blood flow faster in aorta. And when we have, smaller blood vessels, right, we decrease the velocity of blood, right? That's what it is. Why is it this way? Because of total cross-sectional area, right? So over here, you can see it. Here's the flow of the blood in the aorta, right? So it's flow fast, and then we have like arterioles, and velocity decreases, very slow in the capillaries, and then it kind of like picks up again in the venules and veins, right? Now, I don't want to confuse you, but remember how we said the flow of blood equals pressure gradient over resistance, right? So you would think, because this is low resistance, because it's a very, it's a big diameter, right? So low resistance. And then you increase the resistance over here. So when you increase the resistance, so what happened? When you increase the resistance, you decrease the blood flow, right? So pretty much it would, so that's a lot of resistance over here. When you increase the resistance, you decrease the blood flow. That's well, you're looking at total cross area over here, but the point is that in a aorta, large blood vessels, the blood flow faster, and in the small blood vessels, it's actually flow slowly, right? Okay. Next, how we can regulate, right? How we can regulate how much blood flow to my muscles when I'm resting and when I'm exercising. When I'm resting, I want less blood flowing to my muscles, right? When I'm exercising, I want more blood flowing to my muscles. Right? Do I always want to kind of increase my heart rate, increase my cardiac output? How about if I just, if I'm just doing some, just regular stuff. I don't want my heart every time when I need more blood flowing to my skeletal muscles. I don't need every time my heart to increase the heart rate. That's just not healthy, right? So is it any other way to regulate the blood flow, for example, to my muscles or to my digestive tract? Think about digestive tract. So if I eat dinner, right? So I eat dinner, I sit down, and I really want more blood to flow to my digestive tract, right? But I don't want at the same time to increase my heart rate, and it's pretty much flow a lot, everywhere. So I want my heart rate to keep it low, my respiratory rate, keep it low. But at the same time, I want more blood flowing to my digestive tract, right? For example. So that's what autoregulation gonna do. It's automatic adjustment of blood flow to each tissue in proportion to its requirement at any given point of time, right? And there is two types of autoregulation, metabolic and myogenic. Excuse me. Okay, so for example, what does mean metabolic control? If my tissue doesn't get enough oxygen, declining tissue oxygen, not enough oxygen, right? So I wanna more blood flowing to this tissue. So I'm gonna vasodilate of the arterioles, right? And relaxation of precapillary sphincters. You guys, do you know it or not? So this is, let's say this is arterial, right? And then we have, you know, these capillaries, right? And then we have venules. It's not exactly, you know, how it is, but I don't want to go into more details that we need. So this is arterial, so blood flows this way. And this is called capillary bed. So over here, we have sphincters. Those are just smooth muscles, circular smooth muscles that can either contract or relax. And when they contract, they decrease the blood flow. When they relax, they kind of like open up those capillaries and we increase blood flow, right? So that's what it says. Either vasodilation of arterioles or relaxation of the sphincters, precapillary sphincters, allowed to increase blood flow. And it happened, for example, if your tissue have declining oxygen level, or when your tissue is very active and they start produce a lot of metabolic waste. So when I start using my muscle, I produce lactic acid, I produce potassium, right? I produce carbon dioxide, so lots of waste product, right? And these, those chemicals, right, they will activate vasodilation in this area and you know, more blood flowing to that particular organ or tissue. Okay, so metabolic control, a relaxation of vascular muscle and plus endothelial cells, so those cells that inside the lumen cover the lumen of the blood vessels, they're gonna release nitric oxide, NO, and nitric oxide is a major factor causing vasodilation, so we dilate them even more. And vasoconstriction would be due to sympathetic stimulation. So we can constrict due to sympathetic system. Okay, that's metabolic control. Myogenic control. Myogenic control responds to the stretch. So when we have lots of stretch on the blood vessels, right? Then so lots of stretch. That means lots of blood going over there. So what we want? We want to constrict those blood vessels to allow less blood to the tissue. So again, look. So that's our arterioles. Those are our capillaries, right? Okay, so here's our. So for example, we have lots of stretch over here. And because we have lots of stretch, that means that pressure is high, right? So if we have lots of stretch, lots of pressure, well, we don't want so much pressure in the capillaries, remember? Because capillaries are very fragile. So we just gonna constrict this blood vessel, right? Just constrict it and less blood flowing to the capillaries, right? That's how we regulate these local areas. And when we reduce stretch, then that means, well, not enough pressure, not enough blood, we will dilate those arterioles. That's myogenic control. So here you can see all the factors that affect your peripheral blood vessels, right? The green shows us that those blood vessels will dilate, and the red arrow shows that they will constrict. So here we have autoregulation or intrinsic mechanism and extrinsic mechanism, nerves and hormones, right? So we can see that sympathetic gonna constrict, epinephrine, norepinephrine will constrict to dilate based on type of receptors, angiotensin, constrict, antidiuretic constrict, atrial natriuretic dilate, right? And over here we have all these waste products that gonna dilate, right? Lots of waste, need to pick it up, dilate those blood vessels, allow more blood flowing to this. That means this is very active organ right now. And here's our stretch, more stretch that constrict blood vessels. Long-term autoregulation include angiogenesis. Occurs when a short-term autoregulation cannot meet tissue nutrient requirement, the number of vessels to a region increase and existing vessels enlarge. So we pretty much, if you know, if this is not enough, right? If this short-term regulation that regulates the, you know, diameter of blood vessel, if that doesn't work, then we just grow more vessels, angiogenesis, or vessels became larger. And it's common in the heart when coronary vessels is occluded, or throughout the body in people in the high altitude areas. Okay, and the last part, very important, would be capillary exchange respiratory gases. Okay, so that's another topic, and I already more than an hour, so let's me do it kind of quickly. So diffusion of oxygen and nutrients from the blood to a tissue, and carbon dioxide and metabolic waste from tissue to the blood, right? So that's part of the exchange, diffusion, oxygen from blood to the tissue, carbon dioxide waste from tissue to the blood. Now, lipid-soluble molecules diffuse directly through endothelial membrane. Water-soluble can pass through the clefts of fenestration, show you a picture in a minute, and large molecules through the vesicles. Right, so here's how your capillaries look like, right? They made from these endothelial cells. Some capillaries are fenestrated, that means they have those pores. They also have this kind of cleft. This is tight junction, so where's my cleft? Yeah, right here. So here's the cleft, right here's the cleft. And it's called intracellular cleft, right? So pretty much, you know, stuff can go either through or can go through these pores or through this intracellular cleft. So here you can see that it can be diffusion of lipid-soluble molecules through the membrane. It can be movement through these intracellular clefts. It can be movement through fenestration, right, those pores, or it can be transport via vesicles, large substances. Caveoli are vesicles that are coated by some proteins, like over here. Now, fluid movement is extremely important in determining relative fluid volumes in the blood and interstitial space. So that means how much fluid moves from your capillaries to the tissue. It's important, right? Now, why fluids move from your capillaries to the tissue, right? So what's happening over here? So let's look over here. So we have arterial, right? And we have venous. And here's the capillary. So that's just one capillary that just give you the whole story over here. Now, we do have, in arterials, we have some blood pressure, right? You know, you start with 120/80 and you go down, 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 down. When you get to capillaries, right, arterioles, you up to 35 millimeters mercury, but it's still some blood pressure over here. Now, inside capillaries, we don't call it blood pressure. We call it hydrostatic pressure. Hydrostatic means pressure of fluid. So over here in the capillaries, we have hydrostatic pressure. It's HP, and we have little c. That means it's inside the capillaries, right? Now, you do have hydrostatic pressure over here of interstitial fluid is HPIF, but this should be 0, right? So you have 35 millimeters mercury pressure here, hydrostatic pressure, and you have 0 millimeters mercury pressure in interstitial fluid. So what is your net pressure? Net HP is 35 millimeters mercury, right? That's a hydrostatic pressure. This pressure gonna what? Squeeze the fluids out. So this pressure, you see how it show out, right? So that squeezes stuff out. But you don't wanna just pretty much like squeeze all the plasma out, right? All this, you know, fluid from water from your plasma. Of course, you leave proteins in, but you don't want all this water squeezed out. You want stuff to come back, right? Because you need exchange. You need stuff to go back and forth. Now, what pressure brings stuff back? And this is called osmotic pressure, OP. Osmotic pressure is like osmosis, remember, because we have lots of proteins inside the blood, right? So those are not red blood cells, but let's say those are proteins, right? Some proteins. And those proteins give you concentration gradient. So high concentration gradient, so water start moving back in. So that's osmotic pressure. So when you have osmotic pressure, so inside you have proteins, you have like 26, right? Well, you have pressure inside, osmotic pressure, 26, and you have 1 millimeter mercury pressure of interstitial fluid. So in capillary, OP of C is 26 and intracellular fluid 25. So what is your net pressure? 25 millimeters mercury, and its pressure move fluids in, right? So you have one force that pushing fluid out, right? And another that pushing fluid in. So what is your filtration pressure? Net filtration pressure. So net filtration pressure equals. So you will have hydrostatic pressure, right? Minus colloid osmotic pressure, right? Colloid osmotic pressure. And because your net hydrostatic pressure is 35 minus, and osmotic pressure is 25. So the net pressure is 10, right? And this is out. This is arterial end. In a venule end, the things are changing. The only thing that's changing is hydrostatic pressure. Now it's not 35, now it's 17. Oh, excuse me. So hydrostatic pressure 17, 0 outside still. So net pressure is 17 millimeters mercury. Osmotic pressure is the same. Net pressure is 25 millimeters mercury, right? So here we have 17 minus 25, we have minus 8. So we have 8 millimeters mercury, and this is pressure out. So there's, oh, I'm sorry. Yeah, that's in still, right? Because here, look, this one is bigger. Yeah, this is in, this is out. This is out, this is in. So that's where you have in the arterial end, fluids moving out, and then they picked up back in the venous end. Right, so here's out, here's in. Right, because this is our positive. Look, this the one that go out as bigger than number than the one that goes in. So that's a positive. Here, 17 minus 25 give you minus 8, right? So this pressure that pushes stuff back in. Right, there is a difference like 2 millimeters mercury. So there is more fluid squeezed out than taking back inside your blood vessels. And this will be picked up by lymphatic vessels, right? Now, this is where you read about this stuff, right? Right. So, so let's read very quickly. Capillary hydrostatic pressure tends to force fluid through the capillary walls out. It's greater at arterial end, 35 millimeters mercury, and less at the venule end, 17. Then we have interstitial hydrostatic pressure, fluid hydrostatic pressure, that is 0, right? Then we have capillary colloid osmotic pressure, osmotic pressure in the capillaries. I don't know, uncoded. What is this? It should be osmotic pressure. So that's just all. And this one created by non-diffusible plasma proteins, which draw water towards themselves, about 26, and interstitial fluid osmotic pressure, about 1. So pressure gradient here is 25. Now, net filtration pressure, remember this formula, that's a net filtration pressure. But because this is 0, right? This is 0, and this one is 1, right? So this is the formulas, but you know, sometimes it just tell you net pressure. So here will be a net pressure and here will be a net pressure. So here you can see the formula is net filtration pressure is HP minus OP. That's it. And you don't see this C, this little C or IF, because that's already net pressure. At the arterial end of a bed, hydrostatic forces dominate. At the venous end, osmotic forces dominate. And excess fluid, because we have these differences over here, 10 and 8, picked up by lymphatic vessels. Okay, circulatory shock. Any condition in which blood vessels are inadequately filled and blood cannot circulate normally. It results in inadequate blood flow to meet tissue needs. So circulatory shock means you don't have enough blood in your blood vessels. Why wouldn't you have enough blood in your blood vessels? Why? It can be because you're losing your blood, right? This is called hypovolemic shock. Hypovolemic low volume from large scale blood loss, external or internal bleeding, hypovolemic shock. Now, hypovolemic shock, blood pressure drops, right? Circulatory shock when your blood pressure is extremely low, and it's low because you don't have enough blood. So either because you're losing that blood, hypovolemic shock. Vascular shock, because a lot of dilation. So like people with allergy. People with allergy release lots of histamine, right? And histamine dilate your blood vessels. Now, when your blood vessels are dilated, your blood pressure drops, right? That's vascular shock. Cardiogenic shock, when heart just inefficient and cannot sustain adequate circulation. The heart is so weak that it cannot push enough blood to the tissues, right? And that's it. I'm sorry for the dark stuff, right? So anyway, that was a long chapter, right? I hope it's helpful. I hope you can rewatch it and you can pause it and you can, think about it. You can read those slides, refer to your book, and find some other beautiful videos on YouTube. But I hope you guys get it. You get this physiology of circulation, and I hope I was able to help you. But okay, well, thank you for watching.